for the PG teaching, and this is the initiative of WAP under the guidance of Professor Kalpana Datta, President of the WAP. We have got two experts today, Dr. Amitava Chattopadhyay and Dr. Ditobroto Das, and we have got two mentors. So they are the Mohua Roy and Lopamudra Mishra, and the cases will be presented by Shombrita Laha and other name. The name of the other candidate is the, what is the name of the other?
Promita, sir.
Promita Das.
Promita Das.
Promita Das. Promita Das. So I'll request Professor Kalpana Datta to give permission to start the session. Over to you.
Yes, very good evening to everyone and welcome to this digital board. And I welcome you all on this, I think, third in series, the Sandhya Pathshala. Today is the case of cardiology case presentation will be done by our two PGTs. And there are two very good and academic mentors are there, Dr. Lopamudra and Dr. Mohua. And the experts are there with Dr. Amitava Chattopadhyay and Dr. Ditobroto Das. Both are cardiologists practicing in different hospitality. Like Dr. Ditobroto is a pediatric cardiologist in Apollo Multi-Specialty Hospital in Amri, Mukundapur, and Dr. Amitava, just a minute.
Chattopadhyay.
হ্যাঁ নামটা জানি আমি অ্যাটাচমেন্ট দেখছিলাম ওকে জাস্ট এ মিনিট yes another expert is Dr. Amitava Chattopadhyay. He is a pediatric cardiologist and child pediatric cardiology clinical lead Eastern India, Narayana Super Specialty Hospital, Howrah. Welcome you both in this board, and I request Dr. Ashok Kumar Datta sir, our senior teacher, professor, head of Bardhaman Medical College. Now I think he has joined in Shanti Niketan Medical College. Yes. So welcome to the board. And I request Promita Das, PGT postgraduate student from CNMCH. Now you share your screen and present the case. And I request all the experts, please interact in between. And clinically, it should be clinically based, how to approach a case and how to manage, not by only technical case-based discussion will be there. So now the board is yours. Dr. Promita, you share screen and present the case.
Ma'am, is the screen visible to all?
No, not yet. Share screen karo, share screen. Ageo presentation ta desktop e khule rakho, then share screen and then click the presentation.
Yes, ma'am.
Acha, Dr. Amitava is there? I mean, awaz to pachhi na.
Yes, madam.
Yes,
good evening, ma'am.
Good evening, good evening. Visible and audible, everything is there. I came to know you are far away from Kolkata.
Yeah, ma'am, I'm in Port Blair. So
okay.
For the connectivity is okay, ma'am, but sometimes there might be dropouts. So may I be excused for that time? Thank you.
Okay, continue, please.
Ma'am, is it visible?
Not yet.
Okay, the share screen করতে হবে এরকম ভাবে করলে তুমি শেয়ার স্ক্রিন আগে শেয়ার স্ক্রিন করো তারপরে ওটাকে আপলোড করো
হ্যাঁ এবারে আসছে yes ফার্স্ট স্লাইডে চলে যাও ফার্স্ট স্লাইড স্লাইড শো মোডে করে দাও yes good.
Good evening, teachers, and to everyone. Today, I'm going to present a case of pediatric cardiology, and my mentor is Dr. Lopamudra Mishra, and HOD of our department is Dr. Professor Nepal Chandra Mahapatra. So, child X, 4 years, 7 months old female of Baruipur residency. The informant was mother. The reliability was fair. The date of admission was on 21st December last year, and we examined the child on the second day of, that is 22nd December. The date of birth was 12/5/2017. The presenting complaints were bluish discoloration of lips and nails since 3 months of age. Difficulty in breathing and easy fatigability on crying and activity since 3 months of age. Fever for last 3 days. There was 2 episodes of generalized abnormal body movements with uprolling of eyeballs in the last 24 hours. So, elaborating each of the presenting complaints, bluish discoloration of lips and nails. It was first noticed since 3 months of age, aggravated on crying and playing, and relieved partially by rest. No seasonal variation was noted. There was no differential discoloration in the upper limb and lower limb. History suggestive of cyanotic spells, that is, there was excessive episodic increase in bluish discoloration and irritability during pain, defecation, or any ailments. Cyanosis was more visible in the last 6 months, associated with deformities of nails. Breathlessness on crying and easy fatigability. This was insidious in onset. The child was asymptomatic for the last 1 year of age, then gradually progressed over the last 6 months with easy fatigability while playing and feeding. It used to be relieved on squatting. There was no variation with positional change except squatting. No history of recurrent respiratory infection. No history of LOC prior to the admission. Initially, the breathlessness with playing, running with 2 flights, that was NYHA class 2, but now it progressed with few daily ordinary activities. That is, now the child was in NYHA class 3. Fever was for the last 3 days prior to admission. The mother complained that it was insidious in onset, intermittent, high grade. It subsided on medication. There was not an association of child's rigors, rash, sore throat, yellowish discoloration of urine and skin. Now describing the abnormal body movement, the child was admitted at the emergency at 3 p.m. with generalized convulsion involving all the 4 limbs with uprolling of eyes, which lasted for 10 minutes. This was followed by loss of consciousness, regained after 5 minutes, but remained drowsy. There was similar episode at 11 a.m. on the same day of admission, lasted for 5 minutes, and the child was taken to the local hospital, from where he was referred to CNMCH for PICU management. Convulsion started from abnormal body movement of the left upper limb, then gradually progressed to the whole body. This episode was associated with arching of the body, but resolved by its own. There was no associated fever spike with the convulsion. So, negative history, there was no history of recurrent cough, cold, excess cry, refusal to feed, vomiting, loose stool, urine abnormality. There was no history of suck, rest, suck cycle or feeding diaphoresis. No history of persistent fever, no skin rash. There was no bleeding manifestation. There was no hemoptysis. There was no chest discomfort, palpitation, swelling of the body, syncope. There was no history of limb ulcer, right hypochondriac pain. These are all signs of polycythemia, but they were not given in the history. There was no history of edema, feet, anorexia, vomiting. There's no features of right heart failure. There was no visual problem, headache, abnormal movements prior to this date of admission, and there was no blurring of vision, there was no double vision, there was no deviation of eyeball or angle of the mouth. So there was no history suggestive of ICP, no history of drooping of eyelids, no difficulty in chewing and swallowing. There was no nasal regurgitation, no gagging, no history of trauma, no history of recent vaccination. There was no long-standing or recurrent fever. So there was no history of skin lesions, blackening of fingers. So infective endocarditis was also not given in the history. Past history, known to have heart disease since 3 months of age. Child was admitted thrice at PICU at 1.5 years, 1.7 years, and 2.6 years of age with sudden dyspnea, excessive cyanosis, and squatting while playing. The child visited the cardiology clinic of CNMCH 1 year back when she was advised for surgery, but did not do regular follow-up, only took admission when there was any emergency situation. The child was not on any regular medication. No significant other illness was noted. Birth history, mother was a booked case. 4 antenatal visits were done by the mother. 2 doses of TT was given. IFA tablets were taken by the mother. In the first trimester history, we do not get any history of fever, rash, bleeding, vomiting, no exposure to radiation, no drug intake, no addiction. In the second trimester history, there was no history of PIA, GDM, bleeding, weight gain. Third trimester, there was no leaking TB, no bleeding TB, no history of decreased fetal movements. In the natal history, the child was born out of normal delivery in an institution, and it was a term baby of 2.7 kg and received the birth dose vaccines. The baby cried immediately after birth and was started breastfeeding within 1 hour. The child did not require any resuscitation or SNSO admission. There was no neonatal jaundice. There was also no perinatal complications. Immunization was done as per NIS protocol. Polio card was also shown by the mother. Family history, there was no similar ailment in the family. Also, when I asked the mother about diabetes or hypertension in the family, there was no such cause. There was no history of sudden death in the family. The child belonged to lower middle class as per the modified Kukusami strata. There was no history of consanguinity between the parents, and this child was the only member in the family with such heart disease condition. The development history, normal developmental milestones, dietary history, the child was breastfed for 6 months, upon which it started weaning from 6 months of age, and breastfeed was continued till 18 months. At present, taking feeds adequate protein and calorie. Treatment history, as I have already mentioned in the past history, that the child was admitted thrice in the PICU at 1.5 years of age and 1.7 years and 2.6 years, and was managed for the cyanotic spells and was advised surgery but did not continue follow-up.
Now I request the experts to please ask question on the basis of history. Anything want to know, any extra to be asked or not? The experts, Dr. Kritugotu, Amitabu, Dr. Amitabu, if possible.
Yes, ma'am. Like Paramita, you have taken an elaborate history. So can you just, before going into the very details, I think the last part is the left, development, dietary and treatment history. This slide is left. Once you complete the history part, can you just summarize a little bit?
Yes. Yes, sir. So developmentally, the child was normal. The dietary history was that she was taking regular adequate amount of protein and calorie, and treatment history 1.5 years of age, at 1.7 years of age and 2.6 years of age, the child was admitted with similar history, but not the convulsion. So here I sum up that at present, the child came with 4 complications, 4 symptoms. That is, there were cyanosis, bluish discoloration of the lips and nails. There was associated breathlessness, easy fatiguability, and these were seen from the last 3 months, and from the 3 months of age, along with fever for the last 3 days. And on the day of admission, the child had 2 episodes of convulsion. One at 11 a.m. when the child was advised admission at CNMCH, and during the admission, the child also had 1 such episode of convulsion, which was not associated with fever.
So you have a child who has presented mainly with cyanotic spells,
yes,
admitted for cyanotic spells, but at the same time, there has been documented evidence of seizures.
Yes, sir.
So this child has both, right?
Yes.
You have taken an elaborative antenatal history as well, that I could find. You have taken an elaborative first trimester, second trimester, and third trimester antenatal history as well.
Yes.
Yeah, this one. So you might maybe after you complete your whole history examination, you can just summarize why did you take, or even can you elaborate why did you take, what are the specific importance of the elaborate antenatal history in this pertaining to this case?
Yes, sir. The first
there must be some importance, isn't it? There must be some importance you have taken.
Yes, sir. If there was any perinatal history, or if there was any essential admission where the mother noticed cyanosis from birth, then my diagnosis would suggest something else. And
no, antenatal. I'm asking about the antenatal. You have taken a very good.
Mother has taken any drug or not? Because there are certain drugs which can cause problems with the organs, especially when lithium is taken or any valproate, or the mother was under any particular medication. That history is very important. Also, if there is any infection like torch or particularly rubella.
Right. Maybe these all definitely will come, but maybe more relevant in this particular case will be that did the mother had any abortions or miscarriages before?
No, sir. There was no such history of miscarriage.
Yeah, you have to mention that one.
Okay.
Because most of these children are syndromic associations.
Yes.
So there might be first trimester abortions or even late trimester abortions if the baby has a congenital heart disease. Of all the babies who are born, the rate of incidence of congenital heart disease is 8 to 10 per 1,000. but there are many unborn children who are aborted before being born. So that's an important issue. Also, one of the important history in the family history, I'm sure you will mention it maybe, that whether other children are affected or if the parents are affected or even the one sibling is affected, the rate of transmission or this particular child having a congenital heart disease approximately ranges between different diseases 3 to 5% or 3 to 4%. Go ahead, please. Go ahead with the other ones.
Yes, sir.
Just a minute,
Okay,
Pramita.
Yes, sir.
Dr.
Uh,
Dr. Dutta, you do you want to ask anything?
Yeah, the age of the child you mentioned is almost nearly 6 years, no?
Yes, so 4 years, 7 months, sir.
If you go by the date of birth, I think it will be around 6 years.
Sir, that was 2019. Sorry, sir. It was 2017 by mistake. It is 2019, sir.
Okay. What is the usual age of cyanotic spells? When
So
do you?
usually it starts by 3, when the child is doing vigorous activities within 1 year of age, it starts. By 2 years, cyanotic spells are less common.
Yeah, because here the first one I think you mentioned at 1.5 and the
0.5
last
years, yeah.
so there are
Yes.
3 episodes, and maybe there were some episodes which were did not
Unnoticed.
require admission. There must be some other episodes which have
Yes,
been.
sir, the mother complained of few such episodes when the child was not even brought to the hospital.
Okay, go ahead, please. Thank you.
Dr. Dr. wants, wait, Dr. Pramita.
Yes,
Dr.
ma'am.
Ashok Dr. Sir wanted to ask something. Dr. Ashok Sir,
Yes, I like to ask,
yes, raise hand.
why you have mentioned the no history of hemoptysis?
Yes, sir,
Do-
because history of hemoptysis is very important, because as there is cyanosis, there might be hypoxic conditions, and this can cause any kind of infection. Infective endocarditis chances may be there due to hypoxia. TB is also a cause, and also this child, most of the time they are low on, at times they have calorie deficit. So all this can predispose to a lot of infection, and particularly
Yes,
TB,
so you are thinking
where
of any
hemoptysis
other,
is important.
so you are trying to exclude the other problems in relation to, in addition to this disease, basic disease.
Yes, sir.
So can you tell me whether the disease concerned or disease suffering by patient as per the history is concerned so far, is there any chance of hemoptysis if it is? What is
Yes,
the
sir,
cause of
there
that?
can be a chance of hemoptysis, because since there is cyanosis, I would think that there is an hypoxic episode that is recurrently happening. This hypoxia can predispose to particularly TB bacteria to grow. Also, in chances of infective endocarditis.
No, I am not telling you any other thing. Just from this basic disease, simple thinking of the disease, cyanotic heart disease, you tell me, is there any chance of hemoptysis? Or tell me in other ways, I am directly asking the question, what are the changes of pulmonary vasculature in a case of this type of cyanotic heart disease?
Okay, sir. So, sir, in this case, there will be decreased pulmonary blood flow, which is causing the cyanosis and hypoxia. But initially, there might be increase in the pulmonary blood flow when the pulmonary stenosis is not that severe, probably. And
Paramita,
but
I
I have
think
always
yeah, I think Sir is trying to guide you towards the development of collaterals in the latest.
Yes,
Okay.
Dr. Amita, I am trying to say that as there is a less amount of blood supply to the lungs, there is every chance of the bronchopulmonary anastomosis.
Yeah,
And as there is
collaterals.
variation of the systemic pressure and
Collaterals.
pulmonary pressure, there are chances of the rupture of the vessels, pulmonary vessels, and that can give rise to hemoptysis. In a case of cyanotic heart disease, hemoptysis may be the manifestation or maybe the presentation of the cases in some cases. This is
Yes,
important.
especially at this little bit later age, 6 years, bronchopulmonary
Yes.
collaterals,
Yes,
they might
yes,
end
yes.
up in hemoptysis.
Yes, that is one thing.
That's what Sir is pointing out.
Second important thing was you started that from the 6 months of age, the child is having, say, relief, cyanosis relieved by squatting.
Yes, sir.
Do you think that a 6 months old baby squat? What are the different stages? What are the different possibilities baby may relieve cyanosis from cyanotic spell? Is the question clear? A 6 months
Yes, sir.
old baby is suffering from cyanotic spell. How it can be relieved and what could be the ideal position for that? Older children may squat. What is the position may be taken by the 6 months old baby?
Younger children can can usually just do a niches position, can change the position of the body, can
No, that
No,
is
what will
that
do
is squatting position.
spontaneously?
6 months old baby is suffering from cyanotic spell. How it can be relieved? Who can?
Sir is asking about squatting in equivalence. Squatting equivalence. These are
Very
known
good,
as
very
squatting
good.
equivalence.
Yes, 6 months cannot squat, no?
Oh,
But the
tell
baby
me,
might do something equivalent to a squatting. That's what
you
sir is
tell
asking.
me what are the different Tusso's position for relieving cyanotic spell? Tusso's
head
can tell
I
you.
think,
Head
Ashok
tilts can
this question will be asked during after finishing the examination.
No,
If anything on the history,
Kalpana,
on the base of history, you just ask because she
Kalpana,
has
I am
only
asking the
finished the
history. I am
Later
asking
finish the examination part.
yes, I am
So one
asking
thing I
from
would
the
like
history.
to add, by history, you have to differentiate different cyanosis presenting in the 6 months old, like a cyanotic spell, breath holding spell, and seizure. That three to be kept in mind, no?
Kalpana, I like to
Okay,
mention
you
that
continue the examination part.
she should answer that mother should take the baby and take it the arm. The mother should take the baby, and that is one of the important positions for relieving cyanotic spell of 6 months old baby. Mother should catch up the baby. This is called Tusso's position. There are 5 positions, and this is clinical history part. Mother should take the baby when the baby cries and the baby's cyanosis is relieved. So this 6 months old baby. Okay, continue.
You can just mention that the baby would be pacified while cuddled by the mother. That will mean everything.
Yes.
Okay. So starting with the examination, the child came with GTCS followed by loss of consciousness. On day 2 of admission, the examination was done when the child was lethargic and drowsy. Faces was bluish lips. There was no dysmorphism. Decubitus of choice was lying down. Vitals temperature was normal. Initially, the saturation was 76% on room air in all the 4 limbs. Then later on, it was 88% with 2 liters per minute. Moist O2, same in all the 4 limbs. The pulse was 110 per minute, which was regular and equal in all 4 limbs. There was no pulse deficit, no special character, normal volume. BP was 90/60, that was in the target range. CRT was less than 3 seconds. Respiratory rate was 30 per minute, and it was regular with an abdominothoracic pattern. General examination, central cyanosis with bluish discoloration of lips and nails were noted. There were no differential cyanosis. There was polycythemia. Clubbing was grade 3. No jaundice, no edema, no lymphadenopathy, no hepatojugular reflux. JVP was not raised. Head-to-toe examination, cyanos lips and nails with clubbing. Anthropometry, weight for height is equal to 50th percentile. Head circumference is between 3rd and 50th percentile. Weight for age was between 3rd to 50th percentile. Height for age was 30th to 50th percentile. Now coming to systemic examination, we first elaborately examined the cardiovascular system. Inspection, we saw that there was a slight precordial bulge, visible pulsation. There was no scar, no venous prominence, no skin tag or polythelia. Palpation was done. This was just to confirm the inspectory finding. We got the apex pit at 4th intercostal space just inside the left mid-clavicular line. This was a RV type of apex. Left parasternal heave was noted. On percussion, 1st and 2nd intercostal space was resonant. 3rd, 4th, and 5th was dull in the left side. Left heart border corresponds with apex. Beyond apex, it was resonant. Right heart border dullness not exceeding the right sternal border. Upper border of liver dullness, right 4th intercostal space in the mid-clavicular line, and there was the heart was in a situs solitus position. Auscultation, S1 was normal, S2 was single and loud, S2 maximum loud in the left 2nd intercostal space, and ejection systolic murmur 3/6 early peaking along the left sternal border, maximum in the 3rd and the 4th intercostal space and radiating to the base and back, but not to the carotid. Best heard with the diaphragm of the stethoscope. This murmur had no change with respiration and position. No additional heart sounds like S3, S4, opening, snap, click, and murmur was noted. Neurological examination, the child was drowsy and lethargic. GCS was 13/15. Skull was brachycephaly. Spine had no deformity. Speech was normal, able to say 4 to 5-word sentence. Cranial nerve examination revealed no abnormality. Motor power of all the 4 limbs were 5/5. Tone of all the muscles were normal. No atrophy, no involuntary movements. Reflexes, both superficial and deep, were normal. Plantar bilateral flexion. Sensory, it was responsive to touch and pain. No autonomic disturbances, no meningeal sign. Other system examination: chest, bilateral equal vesicular breath sounds, no adventitious sounds. GI system: no epigastric impulse, no bruit, no palpable abdominal aorta, no enlargement of liver and spleen, no lymphadenopathy. So provisional diagnosis: this is a case of congenital cyanotic heart disease with decreased pulmonary flow with dominant RV, likely to be tetralogy of Fallot physiology, most likely due to be tetralogy of Fallot in normal sinus rhythm without evidence of infective endocarditis in NYHA3 with recent onset CNS complication, likely brain abscess. Should I continue, ma'am?
No, I think
Wait. We ask you the question on the basis of examination part, Dr. Ditubrata.
Promita, just one question. Do you regularly do percussion on in the cardiovascular system examination?
No, sir, not regularly. We do.
So why did you do percussion on this particular
because
patient?
since I was about to present this case, we did, and also percussion has some importance with to rule out pericarditis. So while doing an examination, we should.
Pericarditis, you cannot. No. How can you pick up pericarditis by percussion?
Pericardial effusion or something, we can get a dullness or any.
Usually, if there is pericardial effusion, then you will not be able to feel a good apical impulse, right? So if, if you on palpation, you are getting a apical impulse in the 4th intercostal space in the normal position, you know that there is no cardiomegaly. So you will probably not get any additional information by doing a percussion, and rather if there is a thrombus or something which can dislodge in the process. So you can just skip that part in your examination also, and you can tell that I'm not doing percussion because of this reason. You can, because you will not get any additional information in this, particularly this case.
Sir, in our exam also, should we not mention percussion?
That you can check with your examiners. I am not a routine examiner. You can check with Dr. Kalpana, Professor Kalpana.
Okay, sir.
Because routine just to check the extent of the cardiomegaly. That you had repeated one sentence. You had mentioned one
what
sentence.
Is the auscultatory finding where you can diagnose pericardial effusion? Just putting the statho. What is the name of that sign? Because you were the PGT. No. The pericardial effusion. Once the effusion has developed, you cannot get the pericardial rub. But there is one sign. That is one sign by which, by auscultation at the back, you can jolly well diagnose that it is a case of pericardial effusion. So, can you name that sign? It is the Ewart sign. Ewart sign. You put the statho.
Ewart sign. Yes, sir. Basal atelectasis we get.
Yeah. That is the thing you can diagnose. But you have said you got only vesicular breath sound, no bronchial breath sound. So that proves that there was no pericardial effusion by clinic.
Yes,
one important thing on the slide which you have open, you have your provisional diagnosis tetralogy fellow. There's a little bit of a discrepancy here. S2 a single and loud, and
so this will be right second intercostal space.
S2 is maximum loud, left second ICS. Now the word loud, when you use in the examination, especially in the case which you are presenting, there might be a little bit of a confusion. Okay, so S2 a single maybe because you are assuming that it's a case of tetralogy fellow, then you are being able to auscultate only the A2 part, not the B2 part, and obviously the B2 part will be less, and it should be maximum on the right side. And also on the palpation part, can you go back to the palpation slide, please? Yes. Left parasternal heave present.
Yes.
This goes a little bit, means the diagnosis of tetralogy of Fallot though. Anyway, let's go ahead into the other parts and we'll come back here again.
Achha, I wanted to ask you, in general survey, did you mention the SPO2?
Yes, sir. Yes, ma'am.
Okay. And also, do you want to ask something?
Yes, I like to ask few clinical questions. First one is, I agree with Dr. Devagotu that percussion.
Your voice is low, a bit louder.
Yes. Percussion should never be done in a case of, say, cyanotic heart disease. Or also in other cardiovascular cases, you should not percuss unless and until you are sure about it is a case of pericardial effusion. This is just one word to you, being PG student. Percussion should not be done. And it is not allowed in examination. Also in exam also, you should not percuss the heart, particularly cyanotic heart disease. Second important thing you have uttered, on general examination, you have seen polycythemia. Polycythemia plus. Polycythemia is an investigation term. It is not the examination term. But you have told that polycythemia plus. I think you should say that conjunctival congestion is present. This should be your clinical term is lower palpebral conjunctival congestion is present. Remember the conjunctival congestion though is present, but you cannot detect anemia by clinical examination in a case of cyanotic heart disease because of polycythemia. So polycythemia is an investigation manifestation. It should not utter like this. Now you have told that regarding the second sound and loud, Dr. Amitav, I like to say that as because of rotation, in a case of tetralogy of Fallot, so in the literature and the textbook also, they say that because the aorta is rotated over pulmonary to some extent, so in spite of that, that is the reason why the second sound is loud and single in tetralogy of Fallot, pulmonary sound is usually not audible. Regarding the left parasternal hip term is because the right ventricle is, say, though it is hypertrophic, but till the force of the right ventricle is low. So I agree with Dr. Amitav that right ventricular, say, pulsation may be there, or so hip is a term where there is some, say, severe hypertrophy with increased right ventricular pressure to a great extent. It is not possible in this case in tetralogy of Fallot. So ventricular pressure is at par with the left ventricle, both the cases tetralogy of Fallot. So hip may or may not be present, but usually hip is usually absent. But some, say, thrust may be there. Now, you have told that there is clinical diagnosis of brain abscess here. I don't know why you are telling the brain abscess because of the 3 days history of fever. You are telling it might be a case of, saying the diagnosis is the case of brain abscess. Now remember, brain abscess never present with high rise of temperature. Temperature usually is, so though it is brain abscess, but the presentation usually in case of brain abscess is usually some sort of low-grade fever, unless and until the abscesses are, say, large enough or multiple abscesses are there. So with clinical diagnosis, provisional diagnosis, you should say, I think there may be some CNS abnormality due to vascular accident or other things, because vascular accident is common. Though brain abscess is above the age of 2 years is common, but directly going to the brain abscess, it means that you are theoretically driving the case. But because of the fever, you can say, you can challenge also, the abscess may be there because of the assumption of that. Yes. Now it is up to that, you may proceed with others.
Yes.
Yeah. There was no fever. In the history, there was no fever.
So 3 days is short history of fever.
And it was not swinging. And it was not swinging type of temperature. Most unlikely brain abscess.
No, it might be because the age of the child.
Yes. So the conversion history was there.
Yes.
There is the cut-off side of the 3 years. And before that, it is the embolism, thrombosis, paradoxical thrombosis, and beyond 3 years is brain abscess. But the brain abscess, usually the temperature is much more.
I think, Dr. Shapan, it should not say the cutoff line, it is usually. usually.
Yeah,
Yeah.
It
Usually.
is.
Usually.
Not a
It is usually
Usually.
usually 2 years. 2 years is.
And I think Dr. Lopa is there and Dr. Mohua is there. If you want to comment something, you are invited. Dr. Mohua?
Yeah, yes, madam. I would like to ask you one question. Already the Dritoda has mentioned that why there is less chance of cyanotic spell before 3 months and after 2 years. This is the two question is here. Why there is less chance of cyanotic spell before 3 months, and another question, why it decreases after 2 years. Your patient cyanotic spell started 1.5 years. It is not the common thing in this case. And I would like to tell you that Amitabh sir has already mentioned that parasternal heave is very much uncommon because RV is not suprasystemic. RV and LV pressure is in the same line. So there is no pressure increase in the RV. So RV is not volume overloaded, not pressure overloaded. So you can give us this answer.
Ma'am, earlier the RVOT is not that prominent or that severe, so that we can get in many cases we can get a increased pulmonary blood flow, and so we might not get any history of cyanosis. And even after 2 years, the severity might increase with time, and that can also be a reason.
No, there are various reasons. 5 to 6 reasons are there.
One is stenosis of the infundibulum region.
Okay.
Dr. Mohua, you can answer the question. Whatever you
Yeah,
ask.
basically the thing is that there is,
resident, you just answer.
yeah, there are various reasons. Basically, there is fetal hemoglobin is more in case of newborn. So the oxygen carrying capacity is more. There is PDA opened up, PDA still present. Due to this reason, there is less chance of cyanotic spell before 3 months. After 2 years, what happened? Patients normally learn how to squat or squat equivalence, as well as there is infundibular stenosis is permanent, or there is fibrosis of the infundibulum. Infundibulum is not so much sensitive to the other stimulus. By this way, there is decreased chances of cyanotic spell after 2 years. So your patient's cyanotic spell must have started in at the beginning, may not be noticed by the mother.
Okay, ma'am.
After 2 years, chance
Dr. Lopa, your comment?
Also, one of the questions which sir asked, what are the squatting equivalents? I think the postgraduate should know this one, squatting equivalents.
Actually written in the...
Crossing the legs or rising
Very
the...
good. Very good. Crossing the legs, like sitting cross-legged.
Yes, yes, sir.
Sitting cross-legged, or even while the child is standing, they might stand cross-legged, or even if the mother takes the baby on the lap with the squatting position equivalent. That means or even lying down. So these are the squatting equivalents which are often used physiologically by the child to overcome the situation of cyanotic spells.
Even simple lying down.
Yeah, even simple. That was the last one. Even simple lying down. So that will help. What does the squatting actually do? Can you explain?
Yes, sir.
Physiological, what does it do actually?
So squatting improves the dyspnea and cyanosis by trapping the venous blood in the lower limb. So actually the preload is decreased, and at the same time the SVR is decreased. That is why I'm getting the cyanotic spell. So by squatting, there will be compression on after 2-3 minutes, there will be compression of the lower limb arterial vessels, and so the afterload will increase, the SVR will increase.
Then, yeah, plain and simple, the SVR increases. Correct. The right to left shunt. The right to left shunt will be decreased. That is the main ingredient for the cyanotic spells, isn't it?
Yes, sir.
So the SVR needs to be increased. Fine. So during a cyanotic spell, what other medications do we give? How do you manage the spells? Like in this particular case,
see the management right now, or while I discuss the management part?
Okay. And one more thing that you have told, this particular child had both seizures and cyanotic spells. So when the
Yes, sir.
patient has, like, the cyanotic spells themselves can lead to seizures. So on an
Due to
upfront, when the patient has come to the emergency, how do you differentiate them? That whether it's a cyanotic spell or a seizure?
Yes, sir. Maybe because of hypoxia and the cyanotic spell is causing this convulsion, but also it started from an upper limb and then gradually progressed, and the child remained drowsy even after that. So, and also the child is 4 years now, so cyanotic spell chances are less. That is why
Correct.
there might be overlapping thing might be there, sir.
Amitabh, I think
Yes.
you should explain this. Amitabh, please. You
So in general,
explain.
if it's a seizure, if it's an outright seizure, it has very types of presentations, uprooting of the eyeballs, or it can be partial, or it can involve any other body part. But in general, if it's a fallout of the hypoxia from the cyanotic spell, it's a generalized seizure. It's a generalized seizure followed by a cyanotic, preceded by a cyanotic spell. If you take the history correctly, there will be a cyanotic spell or spell equivalent followed by seizure. Whereas in an outright case of seizure, you won't have the history of a cyanotic spell, and the seizure might be involving any of the body parts. That's a common
in
mistake.
case of-
Mohua, would you like to add anything?
Yes, in case of seizure, the cyanosis will be the last thing to appear. Until
Yes,
under the
ma'am.
respiratory filter is depressed, patient won't have a cyanosis in a case of seizure.
Yes, ma'am.
I'd like to add one thing. Hello?
Yes, sir.
Hello?
Yes, sir. Audible.
I like to, one thing that evaluation of tetralogy of fellows is very important for PG. The resident, you know, the evaluation of tetralogy of fellows is very important. Don't think that at birth, all the cases of tetralogy of fellows is having the pulmonary stenosis of the same range, except two conditions where there is a critical pulmonary stenosis or pulmonary atresia. Usually cyanosis is rare at birth. The cyanosis depends on the degree of pulmonary circulation and how the pulmonary circulation is compromised with increasing age. This is important. With increasing age, the pulmonary circulation is compromised. Gradually, the pulmonary stenosis is increasing, and the reason is still not clearly known, though there are lots of hypotheses, large number of there, but the pulmonary stenosis increases with increasing age. This is important thing. That's why usually we see the cyanosis at the age of usually 4 to 6 months of age in case of tetralogy of Fallot, though the pulmonary stenosis is determined from the very beginning. But at the initial stages, because of the two factors, the degree of pulmonary stenosis and the requirement of the blood flow to the pulmonary circulation, these two things are important for determination of cyanosis. So cyanotic spell or cyanosis may appear from the 6 months, 4 to 6 months of age. Again, you see that another factor determines the degree of pulmonary circulation is the bronchopulmonary anastomosis. There are different gates, three gates of bronchopulmonary anastomosis. The bronchopulmonary or systemic pulmonary anastomosis, gate 1, gate 2, and gate 3, of which gate 1 is very important, that is bronchopulmonary anastomosis. Depending on the anastomosis, how much it is present from since birth, that determines when the cyanosis will appear. Sometimes we have seen some cases where there is no cyanosis at the age of 3 or 4 years, but investigation reveals it is a typical case of tetralogy of Fallot. It means the degree of pulmonary circulation is capable enough to maintain the oxygenation. So cyanosis,
that is pink Fallot.
that is the oxygenation supply, oxygen supply is not fully compromised to develop the cyanosis. This is one thing the PG should remember. So cyanosis may appear late also. Regarding the relief of the different position, which Dr. Amitabh described is Tussaud's position, you should know it. And I request you to go to the library and see the Parloff's textbook of the clinical recognition of congenital heart disease by Parloff. And you will see the Tussaud's position, they're giving very good figure demonstration of Tussaud's position, 5 position. 4 position is already discussed, another person is sitting on the chair. So total 5 is there. So these are the important things. So
Dr. Dhrito, you want to ask?
Yes. So this is the addition to previous discussion. Thank you.
Dr.
No, madam.
Dr. Lopa, if you want to ask some or comment, any comment, any suggestions?
Because it's already almost 45 minutes in this case.
1 hour is there for one case. Don't worry.
Yeah, we are still left with the management part.
Okay, if you want to comment, otherwise we go for the management.
Ma'am, only one thing I want to mention. Hello?
Yes, Lopa, a bit louder.
Yeah, ma'am, only one thing I want to mention that our baby was having this cyanotic spell since 6 months of age, not at first 1.5 years. That was the age when he first presented to the hospital with at our hospital with cyanotic spell. But previous episodes were milder and he was treated at home only, managed at home.
Okay,
Right.
go ahead.
Ma'am, should I continue?
Yes, please.
Yes.
So the differential diagnosis was VSD with PS physiology, that is tetralogy of Fallot, VSD with PS, double outlet right ventricle, VSD and PS together, single ventricle PS, aortoventricular septal defects with PS, corrected, that is the LTGA type with VSD and PS, ASD with PS, Eisenmenger syndrome, and Epstein disease. So management part, on day 1 at emergency, IV midazolam was given stat with moist O2 inhalation at the rate 2 liter per minute. IV bolus NS was given twice, 20 ml per kg, then shifted to PICU. At PICU, the child had similar episode of convulsion, and then injection levetiracetam loading dose was started, followed by maintenance. The initial CBG was 98 mg per dl. Vitals were stable. The patient was afebrile at that point. Saturation was 76% in room air in all the 4 limbs, but later on, after moist O2 inhalation, it increased to 88%. KMIT was done, which was normal, but ABG revealed metabolic acidosis along with hypoxia. Hence, injection sodium bicarbonate was started with slowly 2 milliequivalent per kg after dilution with distilled water. Injection metoprolol was started with 0.05 mg per kg along with ketamine 1 mg per kg bolus, followed by 0.01 mg per kg per hour infusion. 3% NaCl was also started at 1 ml per kg per hour. Child was put to Nietzsche's position. Injectable antibiotics and paracetamol was started. Child was advised NPM and IV fluid isolate P was given according to Holiday-Seger formula. Ophthalmology refer was done. After 12 hours on day 1, fever episode was 1. So one single episode since admission. It was temperature 101 degree Fahrenheit. The vitals were stable, drowsy, the child remained, but responded to the commands. Urine output after 12 hours was 2.5 ml per kg per hour. The child was kept NPM and continued the same advice. ABG was repeated. It was now corrected and normal. Pupils were bilateral reactive. Eye refer revealed no papilledema, no retinal changes were noted. An urgent NCCT was done on an emergency basis, which showed a parietal SOL. So routine investigation on the initial 12 hours gave us a complete hemogram with a hemoglobin of 18 gram per DL. No abnormal cell was noted in the peripheral blood smear. Fever profile was sent urgently, which was negative for most of the things till 12 hours or for 24 hours. ESR and CRP was not freezed. Urea, creatinine, sodium, potassium was normal. LFT was normal. Urine RE ME was normal, and 3 days later we got a CS report to be normal. So we advise for ECG, EEG, MRI brain and echo. Subsequently, chest X-ray was done in the PICU emergency basis only. That showed a boot-shaped heart with hyperlucent lungs, diminished central hilar pulmonary vessels, and an upturned cardiac apex. Main pulmonary artery segment is flat to concave, and the right aortic arch is same. So ECG was also done, which showed a right axis deviation that is suggestive of right ventricular hypertrophy with upright R wave in the V1 and predominant S wave in the V6. Then on D2, the child showed improvement. There was no fever in the last 12 hours, no convulsion in the last 12 hours. Saturation was 89% in all the 4 limbs with moist O2 inhalation at the rate 2 liter per minute. Vitals remained stable. The child was responding to commands but was a little drowsy. The blood glucose in the next day morning was 103 mg per dl. ABG was normal in all the parameters except PaO2, which was less than 40. After 24 hours of convulsion free, we started on oral diet and oral medication. Child was shifted to the ward. Antibiotics was continued. Oral propranolol was started. That was at the dose of 0.5 mg per kg every 6 hourly. Injection 3% NaCl was tapered to 0.5 ml per kg per hour and then omitted. Injection ketamine was also omitted. And now since the child was stable, we planned for a 2D echo and an MRI brain. So 2D echo, I have elaborated it with the help of Lopaman. So situs solitus was noted, levocardia, atrioventricular and ventricular atrial quadrants was normal related to great arteries. Dilated RA and RV was noted with right ventricular hypertrophy, aortic override with less than 50%, subaortic anterior malalignment type of large VSD was noted with low velocity flow. Moderate infundibular plus valvular PS was noted. The gradient was 55 mm, but the infundibular part was much more than the valvular. Pulmonary valve annulus was 10 millimeter. Confluent branch pulmonary arteries, each of 7 mm. Left aortic arch was seen. Descending end of thoracic aorta at diaphragm 10 mm. All the valves except the pulmonary valve appeared to be normal. So then two coronary artery systems with proximal coronary arteries appeared. Normal biventricular function without any regional one motion abnormality. No significant ASD, PDA, additional VSD, no clot, pericardial effusion or vegetations were noted. So the impression was a tetralogy of Fallot with moderate valvular plus infundibular PS with good size confluent branch pulmonary arteries. EEG was done, which was normal, and MRI brain revealed left parietal brain abscess of 4 into 5 centimeter. On day 5, that is the day of transfer, actually we transferred the child to neurosurgery department. The antibiotics were continued. Oral iron was given at a low dose of 0.5 mg per kg per day. Oral Livera was given at a max dose of 40 mg per kg per day. And neurosurgery opinion was taken in between these 5 days, and they suggested for a transfer in their unit where they were further planning for a drainage or a surgical removal of the brain abscess. So further, the goal of management overall was in a cyanotic spell child, we have to first reduce the anxiety to calm down the pain so that the heart rate is reduced. Vasodilation is needed, and we should follow algorithm-based management. Volume replacement is important because there is a metabolic acidosis. We can't keep the child at an acidotic and dehydrated state. To control the heart rate, we can give beta blockers along with alpha-1 adrenergic receptor agonist. Arrhythmias might develop in such patients, and we should control that. Fever also needs to be controlled. Long-term management plan and parental counseling is very important. In our case, the child was neglected. The surgery should have taken place before 1 year at least, but that was neglected. So that is very important. Catheterization or surgical intervention for non-responders are also a thing. Summary of management: aim for therapy, providing an immediate increase in the pulmonary blood flow to prevent the sequelae of severe hypoxia. So the non-pharmacological therapy is triaging hospitalization, niches positioning, or positioning the baby to mother's lap. We have already discussed that, and that is to reduce the venous return and to increase the systemic venous pressure. So oxygen inhalation is given, and we can also give nebulization in the severe cases. Even ventilation is needed. Drugs we give, preferred sedatives are given along with beta blockers. Before doing any IV channel or before starting any medication, we should first relieve the pain. So morphine 0.1 mg per kg subcut or intramuscular is the first thing we can give. Since we didn't have morphine in our case and the child also had history of fever, we started with paracetamol and then gave the other things. Injection metoprolol 0.1 mg per kg was given slowly, and then 3 to 5 microgram per kg was given in a continuous infusion. Ketamine dose is 0.2.5 to 1 mg per kg. We can give it IV or IM. Second line of drugs are beta blockers, propranolol, esmolol, alpha-1 adrenergic acidosis state. Along, if dehydration is there, it will precipitate the spells more. So normal saline infusion is given 10 to 15 ml, and then we can give the maintenance fluid according to Holiday-Secker formula. If we find that the child has a hemoglobin less than 12%, that can trigger cyanotic spells, so we can give packed RBC. Acidosis should be corrected. Here in our case also we gave sodium bicarb, and control of fever is also very important. Tepid sponging can be done, and control of arrhythmias, we can give antiarrhythmic drugs. Adenosine is given 0.05 to 0.1 mg per kg bolus over 1 to 2 seconds. This can be repeated. If we fail to do so, we can actually start with beta blockers or digoxin. Non-responders, we actually advise for invasive ventilation or catheter, catheter intervention we allow. Palliative surgical intervention, log tossing shunt is usually done in patients who are not responding to medication, or where the child is of a lead 2.5 kg or less weight, but the definitive is corrective surgery. Prevention of cyanotic spill, as I've already discussed, propranolol, iron supplement, parental counseling, and education. That's it. Thank you.
Paramita, you seem to have read the chapter very well. You have depicted all things. Can you go back to the X-ray slide, please?
Yes, sir.
I'll just take 2 minutes time.
Yes.
Yeah, that's one. The apex is upturned. Definitely, it's an RV event, but probably the pulmonary bay is full. There is a little bit of a right atrial enlargement. Pulmonary blood flow is definitely decreased, but the typical appearance of a titillogio fallow, where there is a coving of the pulmonary bay, seems to be full. So in this case, probably along with your other findings that the branch pulmonary arteries were quite good size, 10 millimeters each, with a good Magbull's ratio, and the pulmonary stenosis was only 55. So probably this goes more in favor of a VSD PS rather than a pure titillogio fallow. Though the points against this is the presence of cyanotic heart disease, and I mean the presence of cyanotic spells. So I think Drito, Mohua, and our respective teachers. And one more thing, in one of the slides in the management, I think it was a slip of pen. You have written vasodilatation, whereas you have given all the pulmonary, all the systemic vasoconstrictors. So that would be vasoconstriction. Yes, I think that was a mistake.
Yes.
And anyone, all the others say you have given all the medications and everything.
Actually, Amitavo,
Sir?
because this is the PG class, this is the PG class. Many of the PGs have attended this seminar, and
Right,
this chest X-ray is not giving a clue of the right ventricular hypertrophy, because the tip is just going downward. And another thing is that the pulmonary conus, if the atretic pulmonary artery is there, there was on the left side. Can you please show me the X-ray? Can you go to the X-ray? Yes. And if you just follow the left border of the heart, there is no concavity for the atretic pulmonary conus. So I cannot see any pulmonary atresia. Okay. So possibly what Dr. Amitavo Chattopadhyay was trying to tell you, that possibly it is better to say the Fallot's physiology, not Fallot's tetralogy, on the basis of the X-ray. On the basis of the X-ray. Please proceed, Amitavo. Amitavo, please proceed.
Apex is upturned. It's RV kind of apex, and right aortic arch is beautifully shown. Only problem.
I cannot show you the X-ray of the right upturn because I have got plenty, but it is not possible at this right moment to show you that. It is not a typical boot-shaped heart.
Because the PA is not empty. The pulmonary bay is full, which is against the pulmonary stenosis. Against the top.
Yeah, that's the reason it's not a boot-shaped. That's the reason it is not a boot-shaped heart.
Apex is upturned and right aortic arch is beautifully seen.
Pramita, can you go to the echo slide?
Yes, sir.
Dr. Amitavo, before echo, just discuss the ECG.
Yes, the ECG, where you can see it's a normal sinus rhythm. It is shown the right axis deviation because lead 1 and both lead 1 is negative and lead AVF is positive. The interval seems to be normal. On lead V1, I could see V1. Yes, there it is just a borderline right atrial enlargement because the P wave is touching about 3 square, I mean, just 3 squares. And V1, V2, V3, the typical transition, early transition is not seen. I think Mohan Dhitrupata will also agree, and all others will agree. The
Yes,
typical early transition not seen.
early
Rather,
transition not
in
seen.
our terms, all the QRS complaints are monophasic,
Yes.
which goes a little bit against the Fallow's physiology or tetralogy. All the chest leads are monophasic, which goes more in favor of a single ventricle physiology. I don't want to complicate the things for the postgraduates here, but this is not a very typical ECG of a tetralogy of Fallow. In a typical ECG of a tetralogy of Fallow, you would find equiphasic R and S waves, most probably in V2 or V3, because of the presence of the large VSD. Okay, this is known as
hypertrophy.
Yes, ma'am, right ventricular hypertrophy. And this is known as early transition, where the R and the S will be almost equal in V2 and V3, signifying the presence of the large VSD. Mohan Dhitrupata, any points?
Yeah, I think that's absolutely fine.
ECG is not typical of tetralogy of Fallow's.
Yes, ma'am. This is not typical of the tetralogy of Fallow. That's what it says.
Not classical for the Fallow.
Can you go to the eco slide? Yeah, I think there is a mistake because you have left aortic arch here in the echocardiography, because on the X-ray we have seen that it is right aortic arch, so cannot be a left aortic arch on the echocardiography, right?
Yes, sir. Yes, sir.
Another thing you have mentioned that the right ventricle is dilated. Can you explain why the right ventricle will be dilated in a tetralogy of Fallow?
So because the right ventricle is receiving the amount of blood from the right atrium as well as from the left ventricle.
Why right ventricle will get blood from left ventricle? You have mentioned it is bidirectional flow in the next line. Is it a volume overload of right ventricle in case of tetralogy Fallow, or it is a pressure overload? What do you think?
So there is a concentric variety.
What do you mean by concentric variety?
So the growth will be mostly in TOF. We see that.
You mean that it is a concentric ventricular hypertrophy, right?
Because of the PS.
Because of the right ventricular outflow obstruction, it is a pressure overload of the right ventricle. So there will be concentric right ventricular hypertrophy. So you usually do not expect dilated right ventricle in tetralogy of Fallow. Okay.
Actually, that would mean the RV is failing, which is probably not the case here.
Yeah, there are a few an exception.
Yeah,
but we'll probably not go into that. But in case of usual tetralogy, the RV is usually hypertrophied only. There are rare exceptions, but don't go into that. It will not be usually volume overloaded. It will be a pressure overloaded right ventricle, which is a hypertrophied right ventricle.
So one thing I should say.
I should
say to the PG, please don't say that in tetralogy of Fallows, the blood is coming from the left ventricle to right ventricle because of BSD. Never say like this. Never say like this. Because it is the pressure of the both the ventricles are same. So remember this. Never say like this. Pulmonary circulation depends on the degree of pulmonary stenosis. When the right ventricle is not able to pass the blood through the pulmonary artery, it will pass the blood to the aorta, because the aorta is overriding the right ventricle. So this is important thing. Don't say the blood is coming from left ventricle to right ventricle. This is one thing. And another thing I like to mention, you have written peripheral blood smear is normal. Is it possible in this case? You are saying the peripheral blood smear normal.
And if it is normal, then why did you give the iron?
So you never say like this. You just you should actually verify. Usually it is microcytic hypochromic type of varieties. So normal, it is unexpected in this type of cases. Okay, only these additions. And regarding the X-ray, and other discussion, I agree with my other members that you should present the case with Fallow's physiology, not directly going to diagnosis of the Fallow's.
Ashok, your hand is always
Dr.
raised.
Shokun,
Can you make it down?
Yes.
Ashok,
already we have passed 1 hour. And
Your
there are few
hand is
questions.
Yes.
So the quick answer of the questions we request the experts please answer the questions.
Should we move to the second case?
No, there are few questions. One question, why Parkinson is not allowed in the exam? So Dr. Ashok Dutta sir, I'm told not allowed. So what is your answer, sir?
Madam, our expert and the presenter can answer in the chat box.
Yes.
So we are already 5 minutes late. So can we move to the second case? Can we move to the second case? The Promita Das, no?
Yes. Sir, mine is over.
Okay, thank you, Promita, for nice presentation, and you faced bravely to all the examiners. There are 6 examiners in front of you. You answered alone. So
Thank you, ma'am.
wonderful.
Well done, Promita. Well done,
Thank you, sir.
Yes,
Thank you.
I request Somrita Laha to present the next case. Please answer the questions in the chat box.
And I will request our experts, 3 experts are there. They can also answer the question in the chat box, please.
Good evening. My patient, Master AH, 3 year 2 months old Muslim male born of non-consanguineous marriage, coming from Baripur, South 24 Parganas, West Bengal, was admitted in the hospital on 18th February and was examined on the same day. Chief informant is mother, whose reliability is good. The chief complaints are recurrent episodes of cough, cold, fever requiring hospital admission in infancy and failure to thrive. The patient was apparently well till 1 month of age with no feeding difficulty and apparently well weight gain. Thereafter, mother noticed there was some feeding difficulty. During breastfeeding, the child would pause in between sucking, rest for a while with rapid breathing, often getting lethargic and going to sleep, and then awaken up with hunger, cry, and restart sucking, suggestive of a suck-rest-suck cycle. Along with this, there was forehead sweating during feeding, while the child was comfortable at rest, suggestive of a Ross class 3. At 3 months of age, the child had 1 episode of cough, cold, fever with rapid breathing and chest indrawing, and he needed admission to the local hospital for 5 days for these complaints and was treated with injections and oxygen. During this hospital admission, the parents were told that there is a possibility of heart defect and they need cardiology consultation, but it could not be done at the same place because of the non-availability of a cardiology consultation there. The child had 3 more similar episodes requiring hospitalization at 5 months, 7 months, and 8 months of age, with at least 7 to 8 intervening minor episodes of cough and cold, all treated with oral medications at home, other than these 4 episodes of hospitalization. And these frequent episodes continued till the child was 1 year of age, 1 year old. During these episodes of respiratory infections, he was having rapid breathing and chest indrawing with forehead sweating at rest too, suggestive of deterioration to Ross class 4 during intercurrent illness. Minor episodes of respiratory infections continued in 2nd year of life, but he did not need any further hospitalization. After around 2 years of age, these episodes of cough and cold decreased in frequency and severity, and the frequency was noticed by the mother to be same as peers of same age group. With improvement of other symptoms like feeding difficulty and chest indrawing, no more hospitalization was required. After birth, there was adequate weight gain till 1 to 1.5 months of age, after which mother noticed that the child was not gaining weight properly as compared to the peers, but she cannot specify the exact weight at that point of time. After around 2 years of age, though, she noticed that the child was somehow catching up on growth, but still not as well as the peers or his older sibling. At present, he has no breathing difficulty, no fatigue on exertion, and no activity limitation. And at present, he is of functional class Ross 1. After discharge from hospital at 5 months of age, he was seen by a cardiologist for the first time, who said that there is a hole in heart, prescribed medicines in the form of a drop and a tablet, which relieved symptoms partially, and was advised that the doctor advised them about need of close follow-up and then one-step cardiac surgery at around 1 year of age or earlier if there was no improvement of symptoms. Though the parents continued medications, but they did not visit cardiologists again till 3 years of age, and the intercurrent illnesses were treated by their pediatrician. They did not visit the cardiologist till this late because they felt that the child was getting better, specifically after he was 1.5 to 2 years old. At 3 years of age, the parents consulted a cardiologist who said that the child needs a procedure through groin. At 3 years of age, the parents and they say that the child needs a procedure through groin, and thereafter can be told whether he can undergo open heart surgery or not, and ask them to continue the medicines. At present, the child is admitted in the hospital for a procedure through groin. There is no history of bluish discoloration, spotting, or cyanotic spells. There is no history of unusual increase in precordial activity at rest or on exertion felt by mother, suggestive of palpitation. There is no history of chest pain. There is no history of pedal swelling, abdominal distension, nausea, vomiting, or loss of appetite. There is no history of prolonged fever associated with skin lesion, hematuria, or color change of fingers or toes. Past history as depicted in the history of presenting illness. Treatment history: at present, the child is on a drop that he takes 0.5 ml twice a day, and a tablet, a small tablet that he takes half tablet twice a day. Birth history: the child is a second order child, was born at term by vaginal delivery at the local hospital, cried after birth. Birth weight was 2.7 kg. Otherwise, the immediate postnatal period was uneventful. Immunization: he is immunized up to date till 2 years of age according to National Immunization Schedule. Developmental history: there is no gross developmental delay. There is no significant abnormality noted in the personal history. There is no history of congenital heart disease in the family. The child has got one elder sibling who is doing perfectly well. According to socioeconomic history, they fall in the upper lower class according to Kuppuswamy scale. So to summarize the history, is a 3-year, 2 months old boy born of non-consanguineous marriage with history suggestive of increased pulmonary blood flow in the form of suppressed suck cycle, diaphoresis, and recurrent chest infection, starting at 1.5 months of age and continuing throughout infancy, with failure to thrive, functional class of Ross 3 with deterioration to class 4 during intercurrent illness, with apparent symptomatic improvement after 2 years of age, diagnosed a congenital heart disease at 5 months of age, and was advised about the need of cardiac surgery. At present is asymptomatic in functional class of Ross 1.
Well summarized from Nita. So just a quick question. So you have given the history. I'm taking the history quite elaborately. So that now the patients, he is about 3 years, 2 months.
Yes, sir.
Yeah, the last slide, please. So there has been, I think, the admission has been more than once, if I'm correct. The admission.
Yes, sir. There were 4 hospital admissions during his infancy, and then now.
Right. So the baby, there is some hole in the heart, and the baby has been admitted with repeated ill-RI.
Yes, sir.
Right. And the parents have admitted the child this time for some procedure.
Yes,
most presumably for the closure of the some shunt.
Yes, sir.
Fine. Some left to right shunt, because the history is suggestive of some large left to right shunt with gross failure to thrive and the child suffering, and admitted almost 4 times. Right.
Yes, sir.
Go ahead with the clinical examination, please.
So should I say the impression from history?
Yes, go ahead, and then after clinical exam.
So the impression from history would be acyanotic heart disease with increased pulmonary blood flow, possibly a large post-tricuspid left to right shunt lesion with, at present, there is decrease in shunt volume, possible due to anatomical restriction in shunt because of VSD being restricted by muscular growth, AV valve or an aortic cusp, or development of pulmonary hypertension in a case of VSD, complete AV canal or PDA, or development of RVOT obstruction, acquired PS or Gozul phenomenon in a case of VSD. On examination, the child has a pulse rate of 100 beats per minute, regular rhythm, fair volume, no radioradial or radiofemoral delay, no special character. Respiratory rate is 20 per minute, abdominothoracic, there is no accessory muscle working. Saturation is 95% in both upper limbs in room air and 94% in lower limb. Blood pressure is 86 by 50 millimeter of mercury in right upper limb and 90 millimeter of mercury systolic in lower limb. JVP is not raised and hepatojugular reflux is negative. There is no pallor, cyanosis, clubbing, icterus, or edema. On anthropometric examination, his weight is 13.2 kg, which falls in between 3rd and 50th centile, and height is 94 centimeter, which also falls between 3rd and 50th centile, suggestive of wasting and stunting. And BMI is 14.9 kg per meter square, which falls in the category of underweight. On head-to-toe examination, there is no extracardiac anomaly or no spine deformity. I'll continue.
Yeah, please go ahead.
No question on history? Dr. Amitabh or Dr. Victor?
Yes, ma'am. Yes, ma'am.
No question in history? It's okay?
No, I think it is fine.
Yeah.
Okay.
We'll ask him at the end, ma'am. At the end.
Okay. Thank you.
On precordial examination, I would like to club inspection and palpation. There's a precordial bulge. Apical impulse is palpable in left fifth intercostal space, 1 centimeter lateral to left mid-clavicular line, which is hyperdynamic in character with medial retraction, suggestive of LV type of effects. There's a palpable second heart sound at left second intercostal space. There is no thrill, impulse, or abnormal pulsation, no scar or venous prominence. On percussion, left cardiac border corresponds to apical impulse and right cardiac border is retrosternal. Right and left second intercostal spaces are tympanic. Upper border of levadoulus is at right fifth intercostal space and stomach tympanicity is on the left. On auscultation, the first heart sound is normal. The second heart sound is appears single, probably because of a very narrow split, and the P2 component is loud. There is LVS3 present, no S4, no cliff. There is one grade 2/6 soft, low to medium frequency early systolic murmur, heart best at the left lower sternal border at around 5th intercostal space, with diaphragm in supine position with no radiation, no change with inspiration or passive leg rising. Other system examinations are, there is no significant finding in other system examination. Respiratory system, he has bilateral vesicular breath sounds, no adventitious sound. There is no hepatomegaly, and CNS and other systems are normal.
So please give your diagnosis, a differential diagnosis.
Yes, sir. So my diagnosis would be situs solitus levocardia, acyanotic congenital heart disease with increased pulmonary blood flow, large post-tricuspid shunt, possibly large non-restrictive VSD, with severe pulmonary arterial hypertension, which is likely hyperkinetic, but need further assessment. In sinus rhythm, no congestive heart failure, no infective endocarditis, good left ventricular systolic function in functional class ROS1.
Yeah. In just in the fourth line, you have mentioned large post-tricuspid shunt, large non-restrictive VSD, but probably this was the diagnosis to begin with, isn't it? But now, presently, when the child is presented to you now, you have shown a slide where there might be some restrictions, either through development of pulmonary hypertension or through aneurysm formation or through some form of a muscular pulmonary stenosis formation, isn't it?
Yes, sir. So that was my impression from history.
Correct. That's your impression from history. And on the clinical examination also, you have supported that one, isn't it?
Yes, sir.
On your clinical examination.
Yes, sir.
Isn't it?
On clinical examination, there is cardiomegaly with loud P2, and there is a early systolic murmur. So more likely this apparent improvement, symptomatic improvement that the child is having is because of development of pulmonary artery hypertension than acute PS or decrease in anatomical shunt.
There is no thrill, na? Somrita, is there any thrill?
No, ma'am, there is no thrill.
Okay.
And going in the fact that there is no thrill with the loud P2, then
Yes,
probably the child is somewhere in between development of pulmonary hypertension, or you mean to say that the difference of pressure between the left and the right ventricles are not that much.
No, sir. Yes, sir.
That the pulmonary hypertension may be dynamic type also.
This is
May not
this
be
is
obstructive yet.
now this is more likely a borderline pulmonary hypertension, but there are some features of hyperkinetic pulmonary hypertension, and but the only thing that is the few things going against pulmonary hyperkinetic pH is that the saturation is 94-95%.
Go to your diagnosis again. Yeah, you have mentioned all the features. I think as a customary to mention all the points. So you should write the page. Oh, you have written no congestive cardiac failure. That's very important to mention. Yes. And in diagnosis, it should be comprehensive total diagnosis. In the beginning, you said there's a failure to thrive. That should be also included in your final diagnosis. Not only cardiac part, other parts should be.
Yes.
You know?
Yes, ma'am.
So it's because that is an important aspect of management in case of when you have to considering the management. So final diagnosis, other complications, and if there's malnutrition or failure to thrive, that to be also included.
May I ask a question?
Yes, sir.
So Amrita, probably you should mention about any diastolic murmur as well. Whether mid-diastolic murmur, you have not mentioned, so I assume that there is no
Yes,
mid-diastolic murmur, right?
Correct.
No, sir. So there was no apical mid-diastolic murmur.
Fine.
And-
So another thing in the diagnosis, you have mentioned that it is situs solitus. How do you determine that it is situs solitus from clinical examination and history?
Yes, that is echo diagnosis. Yes.
No,
How do
sir.
you know that
On,
it is situs solitus?
so on percussion, the upper bottom liver turnus is on the right side and stomach tympanicity is on the left. That is why.
That's okay.
One more thing, you have just go to the P2 slide. You have
Yes,
mentioned a single loud P2. Now this can have several meanings. S2 appears single and loud P2.
So I said appears single because it can be a very close, narrow split as well. The child has a heart rate of 100 beats per minute. So that is
I
why I'm
understand.
saying appears single.
But depending on the examiner, it might be interpreted in different ways, isn't it?
Yes, sir.
See,
Yes, sir.
outright, your case seems to be, as you have rightly mentioned, that seemingly it's a post-tricuspid large shunt. At least to
Yes.
begin with, probably there is some restriction in some form or other now. The loud P2 may be due to the fact that there is still some persistent hyperdynamic pulmonary hypertension. But
Yes.
if you mention a single loud P2, that
Yes,
might have several other interpretations.
Yes, sir. We
So
should-
then the examiner, though this is a class mainly for the postgraduates of pediatrics, but the examiner will be tempted to ask what are the different kinds of P2 you
Yes,
can
sir.
have. So
Yes,
can you
sir.
just explain us for the benefit of everyone, what are the different kinds of P2?
So in post-tricuspid shunt,
Yes.
so in a post-tricuspid shunt, that is, if we talk about large non-restrictive shunts, so large non-restrictive shunt with elevated pH, then initially there will be wide and variable S2 with P2 accentuation when the pH pressure just starts rising, and once it's severe pH, as the pH pressure increases, the P2 will come closer, and the S2 will appear narrower than the split was earlier. From the wide and variable, it will be a narrower split. And finally, when there is full isomerization with right to left shunting, the S2 will be single with only the loud P2 component heart.
So Shomrita, I think you should not mention that it is single, because if you are telling single P2, then there is no hope, no scope of even doing cath, na? Better
Yes,
to
that might
avoid
be.
this terminology. Yeah.
Yeah,
Yeah.
it will be interpreted in different ways. Isn't it?
Yes. Single P2 is quite
And it is
bad
not
thing to
going with
have,
the
na?
third sentence. It is not going
Yes.
because you have mentioned LVS3 present.
Yes,
So
yes, sir,
LVS3
yes.
present means that there is a large shunt.
Yeah.
At the same
some
time,
hope is
single
there, yeah.
loud P2 is going against it.
Yes, sir. Yes, sir.
In
It will
that
be
case, you
narrow
would have
split will be better.
diastolic murmur of PR, you would have
No, ma'am.
tricuspid regurgitation murmur. So single P2 is not fitting with this thing.
Yeah, as Rito mentioned, the diastolic murmur should be okay. And one more thing,
Yes,
one
yes, sir.
important thing is, see, you have mentioned in the last slide, Ross classification, Ross stage 1. So for the benefit of everyone, can you just mention the different flights of Ross classification so that all the postgraduates might learn from you?
Yes. So Ross functional class is something we use for pediatric heart failure, mainly till 6 years of age. Ross class 1 means the child is asymptomatic but has a congenital heart disease. Ross class 2 means there's mild tachypnea on exertion, like during feeding, there is mild diaphoresis, mild tachypnea, mild chest and drawing, but the child is asymptomatic at rest. Ross class 3 would mean that there is marked tachypnea, marked diaphoresis during exertion, during feeding, during crying or playing, but the child is again asymptomatic at rest. And Ross class 4 would mean that the child is having this tachypnea, chest and drawing, sweating, and all these tachycardia, all these symptoms at rest as well.
Correct. So, and as you said, up to the age of 6 years, instead of the New York Heart Association classification, we use the Ross classification for small children. Fine. Go ahead with the, go ahead, please.
Sir, I have a question. Sir, can I ask?
Yeah, sure. Please go ahead.
Shomrita,
Sure,
you have
sure.
mentioned upper body saturation is 95% and lower body saturation is 94%. Is it significant?
No, ma'am, there is a difference of 1% only, which is not significant. So the implication here would be if there is associated presence of a PDA, then because of the presence of severe PH, we will miss the murmur. So in that case, by showing differential cyanosis, we would predict, or we may be more cautious about to look for the presence of PDA, but then that means the difference has to be more than 2%, which is not here. So
in your case, it is not significant, isn't it?
It's not significant here, yes.
An important thing. Yeah, please go ahead.
From this, you can tell it is post-tricuspid sound, probably VSD, not the PDA, isn't it?
Yes, ma'am.
Yes, sir.
But
Sir, please continue. Please,
yeah. One good thing, Shomrita, since you have elaborately described your case, just like a navigator who takes the ship from the doldrums towards the shore, you have been taking your case towards a goal. But see, when you have mentioned this particular point which Mohammed raised, then obviously the examiner will be tempted again to ask that what are the points at this point of your case when you have almost finalized your diagnosis, then upper body 95, lower body 94, even if it's a 1% difference, would you expect much of a difference? Because that would mean that there is something fishy going on at the PDA level, some right to left shunt going on. So if this is the case, it is better to, I think it is better to ignore it, that 1%, or just mention that the saturation is 95% at all the 4 limbs. What do you say, Moga?
Yes,
that will further complicate the matter, isn't it?
No, but I think it may be 1% difference we can always accept.
It's always accept.
But what she is trying to impress, that she has noted it to that there is no differential cyanosis.
Right.
She
Go ahead.
invited some question, na, sir.
Okay, another question in the chat box. Another question: Can we say situs solitus in the diagnosis just on the basis of clinical examination? There is a question in the chat box.
Actually, madam, there are two situs, which we refer to in cardiology. One is generally the abdominal situs, and one is the cardiological situs. As you have rightly pointed out, cardiological situs is very difficult to mention clinically, because even if the liver is on the right side and the stomach tympani is on the left side, the cardiologically the interpersonal relationship between the atria and the ventricles can be totally different, even if it's a levocardia. That is difficult to find out unless one does a very detailed echocardiogram.
So I don't think it should be mentioned in diagnosis clinically.
Yeah, what she has mentioned is the abdominal
Every
situs.
examiner expect that after clinical examination, the student should mention situs and the situs solutions and levocardia by clinical examination only.
By clinical examination. That's what
today everyone expect that.
Conglomeration of the abdominal situs and a rough assessment of the cardiac situs.
Yes, sir.
Okay, thank you. Thank you. Just go ahead.
So this is the chest X-ray of the patient. It's a chest X-ray PA view with slight underexposure. The bony cage and soft tissues appear normal. Liver is on the right side, and looks like there is some stomach gas shadow here on the left side. There is prominent cardiomegaly with increased pulmonary vascularity. There is dilatation of the central as well as peripheral branch piers, and we can see the end-ons at multiple places.
Can you be specific? Cardiomegaly, biventricular or right ventricular, left ventricular?
Ma'am, I'm coming to the, yes, ma'am. So it's cardiomegaly with pulmonary plethora with LV type of apex. And then there is dilatation of the main pulmonary artery segment. Then the left atrial appendage is dilated as well. It's difficult to look at the carinal angle here because of the possible underexposure. So we cannot, so by looking at the left atrial appendage, we can comment on the left atrial enlargement, but the carinal spleen is not very well visible here. And the LV type of apex, so there is definitely left ventricular enlargement, and then MPA segment is dilated. The right hilar pulmonary artery diameter seems to be more than the tracheal diameter, suggestive of this the dilatation of the branch pulmonary arteries as well. And then there's some evidence of pulmonary venous congestion as well in the form of prominent upper lower vascularity. And then there is definite pulmonary plethora. So looking at this X-ray, it looks more on the side of a hyperkinetic pH.
So it is actually not a right hilar pulmonary artery. It is the RPDA. And if you have not measured well, it is a 100% taken X-ray. There is a measurement of the RPDA. If it is more than 17 millimeter, then we can call it is the dilated RPDA. Am I right, Dhito?
This is adult criteria,
I don't
sir.
know upon that.
Sir, this is
No,
adult
Dhito
criteria.
raised hand. Long back, Dhito raised hand but didn't say anything. Dr. Dhito.
No, I said I forgot to lower my hand. I'm lowering.
Hello.
Madam, this 17 millimeter is adult criteria for, I think it's adult for female
okay.
adult, it is 17. So in pediatric, what Somrita is trying to say, it is compared with the tracheal shadow, tracheal diameter.
If it is more than the tracheal diameter, then we can, but is it a very good measurement criteria?
No. It's very vague.
No, she said it is the right hilar pulmonary.
In front of examiner, you have to tell those things.
No, we are not examiner. We are not.
No. Somrita is preparing for exam. So, Somrita, tell us about how do you measure or how do you classify increased pulmonary blood flow in X-ray? Tell us the criteria. Yeah.
The signs of increased pulmonary blood flow would be one is uniform dilatation of the hilar as well as peripheral branch piers in the form of dilated MPA and hilar branch piers, as well as peripheral vascularity extending more than middle 1/3 till lateral 1/3. This is one. Second is the presence of end-on vessels, which is the when we see the cross section of the pulmonary vessels on end-on, they appear to have a size more than the adjusted bronchiolar end-on. So this is one another thing. And then this pulmonary venous congestion, if we find there, it may be difficult to appreciate the pulmonary plethora in the upper lobes in the presence of PVH. But then in the middle and lower lobe, we can definitely say that there is pulmonary plethora.
Did you mention the cardiomegalies?
Yes, ma'am. I talked about cardiomegaly and LV apex and.
Is it biventricular? Is it biventricular?
Ma'am, this is the apex type is left ventricular. Whether the right ventricular is enlarged or not, we cannot say definitely from this X-ray. We would need a lateral film to say that.
Yes, retroexternal space.
So we can proceed to ECG.
Yes, continue.
This is a 4-channel 12-lead ECG with normal standardization, with a heart rate of approximately 100 beats per minute, with a sinus rhythm as P is upright in 2-3 and AVF and negative in AVR. And then the QRS axis appears to be at around 90 degree as the AVF is positive and 1 is almost isoelectric. And the PR, if you look at the P wave, so there are a few P waves here like this, and this, which appear notched. Most of the P waves appear notched with a longer duration, suggestive of the left atrial enlargement. But if you look at V1, the terminal force in V1 P wave is not that prominent. But taking in account of this notched P wave with increased duration, probably there is left atrial enlargement as well. The PR interval appears to be around 160 to 180 millisecond. Looking at the QRS complexes, there is monophasic R wave in V1, suggestive of right ventricular hypertrophy. But then we have this large RS complexes in the mid-precordial leads, V3, V4, suggestive of biventricular forces. There is a very small inconspicuous Q wave in lead V6. We do not see any definite Q wave in lead V5. So taking in account of, if we take in account of this small non-conspicuous Q wave, then this looks like the PH is probably hyperkinetic. Also taking in account the biventricular forces and the left atrial enlargement. The T wave and ST segment has this no abnormality in other segments.
So your X-ray is corresponding to your ECG findings?
Ma'am, not completely. The X-ray is definitely hyperkinetic pH. ECG looks more like borderline.
As well as LV volume overload was quite evident in X-ray, not in
X-ray,
ECG.
not in ECG. Yes, ma'am.
Please continue.
And show the echo pictures. This is the apical four-chamber view showing dilatation of both ventricles along with dilatation of left atrium, and the right ventricle appears hypertrophic. The AV valves in 2D look normal, other than there's a possible prolapsing movement in the tip of anterior tricuspid leaflet. The apical five-chamber view in color Doppler showing there is no 2D here, so this is probably there is a large VSD here. There is a low velocity shunt. This is the parasternal long axis view, which is profiling the VSD better. So there is a large PM VSD with posterior trabecular extension, as we see here, and then the short axis. There is low velocity, predominantly left to right shunt, as evident by the red flow. And then there is some tricuspid regurgitation, as we see here. This is probably mild tricuspid regurgitation. This is the short axis view profiling the same VSD. From here, it appears to be a perimembranous VSD with subaortic extension, and from here we could see that there is some posterior trabecular extension. So anatomically also is a very large VSD, which is predominantly low velocity left to right shunting. There is increased flow across the mitral valve along with mild MR due to annular dilatation, as we have seen previously in 2D that the mitral valve look morphologically normal. And there is also increased pulmonary venous return, as we can see here. Mild tricuspid regurgitation. So pulmonary regurgitation with a peak pressure of 33. So this suggests you have a PA mean pressure of 33 millimeter of mercury. The suprasternal view showing arch. There is no PDA, as we see here. But this is from this view, it looks like there is no PDA, but we will need further views to confirm that. Ma'am, that's it.
Okay, what complication you can expect in this particular disease? Tell me, just summarize some complications you can expect.
So
Help in the management.
The complications we will expect in this, if we consider VSD, so large non-restrictive VSDs, the complications will be in the form of congestive heart failure, especially during earlier years of life. And then there'll be, and then if left untreated, there'll be development of pulmonary hypertension and pulmonary vascular obstructive disease, and then Eisenmenger syndrome with the complications of Eisenmenger syndrome.
Reversal
Then, sorry, ma'am.
Yes, continue. Reversal of shunt.
Yes, ma'am. So in the form of Eisenmenger syndrome, and then there'll be there can be associated anatomical problems with this large shunt. A large shunt can be restricted by aortic cusp prolapse, which will lead to aortic regurgitation. That is another complication. And then if the large shunt is being restricted by the tricuspid valve, there can be a significant tricuspid regurgitation, as well as being restricted by tricuspid valve, and a damage to the tricuspid valve aneurysm will lead to a left ventricular to right atrial shunt, which will further cause volume overload of the right atrium. Then infective endocarditis per se is not very common in a large VSD because there is a low velocity shunt. But if the patient develops aortic regurgitation or aortic cusp prolapse, these complications, then there can be infective endocarditis as well. And then there is gross failure to thrive, and this because of this large shunt and catabolic state in infant stage and in earlier young years of life.
And thromboembolic phenomena?
Ma'am, thromboembolic phenomenon again, not very common in the VSD, but once a child develops Eisenmenger syndrome, there can be thromboembolic manifestations and other complications for the cyanotic heart disease.
So just continue with the management part.
From the management part, there's not in the slides. So what we did for this patient was, because conglomerating the clinical examination findings, ECG and chest X-ray, we found this patient to have borderline pulmonary arterial hypertension. We did a cardiac catheterization for this patient with for assessment of pulmonary vascular resistance. Should I share that data?
No need, just summarize. Samrita, summarize. What
so,
you have found?
When we did on cardiac catheterization, we found that the child had room air pulmonary vascular, in the room air, when we took the simultaneous aorta and pulmonary artery pressure, at room air, the simultaneous aorta and pulmonary artery pressure, mean pressures were equal. And after acute respiratory testing, after giving 100% oxygen for 10 minutes, we found that there was around 10% drop in the PA mean pressure. But then when we took the samples and we did a full pulmonary vascular resistance QPQS calculations, we found that the room air pulmonary vascular resistance was 5.2 Wood units meter square. And after 100% oxygen acute respiratory testing, it had come down to 1.3 Wood unit meter square. So, and then the PVR SVR ratio after acute respiratory testing was 0.18. The patient underwent surgical closure of PST and has been discharged.
Okay.
Shomrita.
Yes,
Sorry,
yes.
ma'am.
Actually, what we see now in lots of you are doing lots of operation now because of Shishu Shati Prokolpon, and so now we are getting post-operative complications, and we have to manage in our department. So please highlight about the post-operative complications. What operation corrective surgery will do? What are the post-operative complications, and how to manage in short?
I think Amitavo is trying to say something.
Yes,
please,
yes, Dr. Amitavo, please continue.
Madam, yeah, Shomrita, for the benefit of them, you have mentioned the PVRI ratio and the PVRI and the vasoreactivity testing. So after you answer Madam's question, just explain that to the postgraduates, the vasoreactivity testing and the SVR PVR ratio. That's
yes.
all.
Yes, sir. So what ma'am asked about surgery and post-operative complications, in this patient underwent a salvage patch closure of the ventricular septal defect on cardiopulmonary bypass. Salvage patch is basically a treated pericardial patch, and so previously the operations used to happen by ventriculotomy, by cutting through the right ventricle, which used to have more post-operative complications in the form of dysfunctions, scar formation, arrhythmias. So nowadays, what the surgeons do is they close the defect through a transatrial and transpulmonary approach without touching the ventricle to decrease these complications. And after in the standard protocol, so after the surgery on cardiopulmonary bypass, the patient is shifted to the cardiac ICU. Usually, if the child has otherwise no post-operative problems in the form of any post-operative residual, any post-operative significant dysfunction, or post-operative residual significant pulmonary hypertension, usually they are kept ventilated overnight, and the next morning, after again making sure that this residual problems are not there, they're extubated. In the immediate post-operative period for 48 to 72 hours, these patients are maintained on some inotropic support, this initially on infusion loop diuretics, which are gradually tapered off, and then another thing to check is before these patients come out of the operating room, usually a post-operative transesophageal echo is done to see that what I mentioned about the immediate post-operative problems in the form of residual PST or residual pulmonary hypertension. If there is significant residual pulmonary hypertension, then the patients may need immediate pulmonary vasodilatory support in the form of inhalational nitric oxide in the severest cases, and in the not so severe cases in the form of drugs like endothelin antagonist bosentan or PDE5 inhibitors, sildenafil. If there is no significant pH, then we just keep these patients on observation. And then after the inotropes are tapered off gradually in an uncomplicated case, and the loop diuretics are changed to bolus, we also continue some AC inhibitors for these patients with the standard antibiotic guidelines. And then usually by 3 or 4 days, we can shift them to ward from the cardiac ICU. And by 6 or 7 days, we are able to discharge them. The post-operative late complications can be in the form of persistence of LV dysfunction. If there is a very large PST, then putting a very large patch on the IV septum makes the IV septum dysfunctional, and that cannot contribute to the LV systolic function anymore. Along with that, a long time pump run, a long run of cardiopulmonary bypass also makes the patient prone to any post-operative dysfunction. If this kind of dysfunctions are there, sometimes they can even persist after the immediate post-operative phase, especially in the smaller children, in the patients with a big defect, in the patients with a complicated kind of anatomical problems which need long time in surgery. This is one thing. Then the patient can have residual pH, and sometimes they need to continue on the oral pulmonary vasodilators for a long time after the procedure. Then residual defect can be another issue. The residual defects, if they are hemodynamically significant, that is if the shunt volume is more than 1.5:1, then they behave like any shunt lesion. And later, if this continues, may need later on surgery or a device closure of the defect. Then the patch can cause anatomical obstruction at multiple places. So if there is a immediate subpulmonic patch, it can cause obstruction in the RB outflow tract. That can be one issue. Then if the patch is at the area of aortic cast, if it is restricting any aortic cast movement, that can lead to aortic regurgitation and the problems associated with that. So and then the problems with infection and possible later infection in the cardiac.
Now answer Dr. Amitav asked the question.
Yes,
PVR and ratio.
So what we do in a diagnostic cardiac catheterization in these patients is the PVR is pulmonary vascular resistance. One difference between hyperkinetic pulmonary hypertension and what we call Eisenmenger syndrome or the pulmonary vascular obstructive disease is that the pulmonary vascular resistance is low in a hyperkinetic pH. The pulmonary hypertension is only flow related. But later on, if this flow-related hypertension continues, there is endothelial changes in the vasculature, which leads to pulmonary vascular obstructive disease, and then the resistance will come high. But even when the pulmonary vascular resistance is high, there is some component which we call component of reversible pulmonary hypertension. That is, there can be some parts of the vasculature that will react to vasodilator and will dilate. And that way the resistance will come down. This is exactly what we see on an acute vasodilatory testing. Multiple agents can be used. In our center, we use 100% oxygen. We can use nitric oxide as well. Nitric oxide actually will be a better one. Then 100% oxygen, after giving 100% oxygen for 10 minutes, what we do is we do a catheterization, take samples and pressure before giving oxygen and after giving oxygen. And we take pressures from pulmonary artery, aorta, right atrium, and then we take samples from SVC, IVC, pulmonary artery, and aorta, and then we do a calculation of the we take in account the VO2 or the oxygen consumption, and then the patient's hemoglobin status and heart rate and age. And by taking all these things in account, we do a calculation to calculate the shunt volume in the form of QPQS and the pulmonary vascular resistance. And then we index this pulmonary vascular resistance to the patient's body surface area. Along with this, there is a ratio called pulmonary vascular resistance to systemic vascular resistance. So as the PVR will be higher, this ratio will be higher. And as the vascular resistance comes down in the pulmonary circuit, this ratio will come down to be lower. And these are the exact parameters that we see after the acute vasodilatory testing with oxygen, whether the shunt volume is increasing or not, whether the pulmonary vascular resistance is coming down or not, and whether the ratio is coming down or not. If they come down the certain thresholds we use as criteria, then we say that this patient can safely undergo closure of the shunt and there won't be a problem.
Thank you. Nice explanation. One question from my side to Dr. Amitavo, Dr. Dhrito. Actually, we had a patient of post-operative fallows, land up in the emergency with the congestive cardiac failure. So, in other way, the restrictive heart is now became the overflooded heart disease. So, we managed it with the medications and maybe improved. So, my question is there any role of any surgery in this situation?
What was the age of the child, ma'am?
It was, I think, 5 years. And the operation was done long, in 1 year and all. This after many years' time, he developed heart failure, congestive heart failure.
The likelihood that probably there was some right ventricular failure in this case. Mostly the right ventricular failure will occur eventually in these people, but mostly they are in the late first decade or even in the second decade, because the RARV dilatation from the pulmonary regurgitation. Because when we are repairing a tetralogy fallows, we close the VSDs and the right ventricular outflow tract obstruction in the name of infundibular and valvular pulmonary stenosis that is relieved by a transannular patch. While we do a transannular patch, we cannot repair or replace a valve actually. Some attempts have been made to replicate the human normal natural pulmonary valve, but it is not of a very good use. So what has happened is in a normal person, like it's a single way blood flow, that is blood from the right ventricle can go to the pulmonary artery, but not back because of the presence of the pulmonary valve. Here, after the operation, it will be a two-way traffic. That means some blood will be going from the RV to the pulmonary artery, but about half of that will come back again to the right ventricle in the same cycle because of the pulmonary regurgitation. Now, human beings can tolerate this very well, but late in the first decade and late in the second decade, they might have right ventricular failure from the pulmonary regurgitation. But nevertheless, we have seen some people, some children have, in some children, it's happening or occurring much earlier. So this particular child, provided there will be no infective endocarditis, no other causes of right ventricular failure, or no residual VSD, no residual right ventricular tract obstruction, then probably the pulmonary regurgitation has taken its toll and the child presented early.
Sir, it is too early, na? Sir, it is too early. Within 4 years, I think must be some residual RVOT.
Some residual, or that's the last point I said. Most probably there was a residual or residual RVOT obstruction which led to this failure.
But this is treatable, madam. Resurgery can treat such kind of patient.
Okay, then thank you, Moa. So it's a wonderful session, and we learned, and I think all the attendees and the panelists, we learned too much
One
from.
minute,
I,
can I
I,
just ask
I have
one
just
question?
one question. So
I
it is
also have one.
written on the echo that it is from the NHS Howrah. So how did you manage it? So is it your case, Amitabh? It was
Which
written
one,
as
sir?
the. It
Echo
is
from
your case,
Howrah.
Amitabh. The echo that is showing is the NHS Howrah.
This particular
They
on
are
the
well
screen.
connected, sir. They are well connected.
Amrita, just one question.
Yes, sir.
Yes, yes.
First of all, thank you for a very nice presentation. So just one question that why did you decide to do a cardiac catheterization? Is the X-ray and echo not enough to say that this is a reversible shunt?
Sir, the patient had a saturation of 94 to 95%. That is one thing. And then the X-ray was very suggestive. The ECG was borderline. So on echo, we found a low velocity left to right shunt. And
But the
yes,
LP
sir,
was dilated, no?
yes, sir. Yes,
The
sir.
ventricle is dilated.
Yes, sir. Yes, sir. The echo was, yes, sir. The echo was more on the suggestive of a hyperkinetic pH. But because we took in account other things as well. So, I mean, we had excluded respiratory infection, so we did not have any possible explanation for the desaturation.
So ECG and patient, clinically it was borderline ECG and patient, but the X-ray and echo is fine. Isn't it, Shambhita?
Yes,
Yeah.
yes, ma'am. Echo was very much suggestive of hyperkinetic.
Assuring.
And X-ray also, there is quite
X-ray also.
significant.
Yes,
Yeah,
sir.
sometimes,
X-ray also.
Quite a very
sometimes on
big
the
heart.
basis of Drito is right actually. Sometimes on the basis of the ECG and X-ray, you might have taken a chance. But anyway,
Cardiac
there's no harm in
catheterization
doing a cardiac cath.
study, especially for pulmonary vasoreactivity, often misguide us also.
Yes,
That data is
sometimes
often,
it does misguide. Anyway,
Thank you
well
very
presented.
I think time is up. 3 minutes to go. So Dr. Sapon, please wind up.
Madam, what is our next program?
Next again, and then last Sunday, 8 to 10, we'll decide the topic and let you know all. And I'm really thankful to see the attendance, even after having 2 hectic day of Vaxicon. Everyone is joined in this session and learned a lot. So thank you, Dhitobroto. Thank you, Dr. Amitabu. Thank you, Muhua and Lopa, for the mentoring the students very well. And thank you overall the students who prepared and presented such a wonderfully. I'm really impressed by your presentations and preparations.
Actually,
so thank you from my side to all the panelists.
we
Now
also
over to
learned a
Sapon.
lot. We also learned a lot from them, from the experts, from the mentors, even from Shamrita. So excellent case presentation. I would have been blessed if I could place like this in my post-graduation days. Excellent. And thank
At
you.
that time, this WAP OBAP members were not there when you were a student.
And thank you everybody for joining us. And I think in future it will be very much useful for all the PGs. And hope to see you soon on the next month, same time, 6 to 8 to 10 p.m. So I think you were very busy with that Vaxicon. So good night.